All right. Hi, everybody. Thanks for joining. My name is Justin Gardner. This is the Virginia Tech Carilion Wilderness Medicine Journal Club. We're going to be going through the WMS guidelines on hypothermia, 2 related articles, and then we're going to be working through a case. And I spoke with 3 people that were going to be helping me specifically with each part of this case, hoping to kind of make this a smooth transition between each segment of the case. It's going to be involving things we learn about in the guidelines in the articles. So if you pay attention, I think it'll definitely give you a leg up, and please feel free to chime in during the case. It's for students by students. So it's for you to learn, and hopefully it's a good learning environment here. So we're going to start with the guidelines. So I'm going to mute myself and take it away with the guidelines. I enabled screen share, so feel free.
All right. Hello, everyone. My name is Dan. I am an emergency medicine intern at VAMC in San Antonio. I'll start off by saying that I'm away from home with not a great internet connection. So if anyone has any trouble hearing me, just speak up and I'll try to cut the video feed and see if that helps. But I'm presenting the Wilderness Medicine Society Clinical Practice Guidelines for the out-of-hospital evaluation and treatment of accidental hypothermia, the 2019 update that was published in the Wilderness Environmental Medicine Journal. So first of all, I'll get out of the way. Background regarding mechanisms of heat transfer. No talk about hypothermia is complete without mentioning that heat transfer takes place by 4 main methods: convection, conduction, radiation, and evaporation. And for those of us who don't use Celsius or the metric system on a regular basis, the normal human core body temperature is 37 degrees Celsius, and we classify hypothermia as a core body temperature below 35 degrees Celsius. Our body has some physiological mechanisms to prevent hypothermia, chiefly heat retention through vasoconstriction of the peripheral vasculature, heat production through shivering thermogenesis, and some behavioral adaptations, including thermogenesis through exercise, seeking shelter, and donning insulated clothing. Briefly, to overview the methods, as an update from the 2014 guidelines, they convened in a panel of experts to come up with consensus after doing a midline literature search. Their grading is by the American College of Chest Physicians. Level or grade 1 evidence is strong recommendation, grade 2 is weak, and then A, B, and C just designates whether it's high, moderate, or low quality evidence, high being RCTs, meta-analyses, those sort of things, low being observational case series or studies. Some basic pathophysiology of hypothermia. The initial human body response is to generate heat through shivering, which drives an increase in metabolism, an increase in ventilation, increased cardiac output, and mean arterial pressure. As the core body temperature continues to fall below 30 degrees Celsius, you start seeing cardiac effects, and the shivering tends to stop around that temperature. And once you stop shivering, your metabolism decreases. Some neurological manifestations of hypothermia include irritability, confusion, apathy, poor decision-making, and as it progresses to lethargy, somnolence, and coma. And then the cardiac manifestations, especially below 30 degrees Celsius, you get a decreased cardiac output, bradycardia, dysrhythmias, ectopic beats, AFib, and VFib. So now moving into the meat of the guidelines with field assessment of a hypothermic patient, the WMS recommends that rescuers classify hypothermia as mild, moderate, severe, and profound based on the temperature ranges that are listed there. And you may not always have access to core temperature measurements, so you should be using clinical observations and factors to guide your treatment, including the patient's level of consciousness, their alertness, their shivering intensity, their ability for physical performance, and their cardiovascular stability. They do make mention of 2 alternative classifications of hypothermia just to juxtapose it to what they're recommending. They're recommending kind of a 4-tier classification of mild, moderate, severe, and profound. One of the most well-known ones is the Swiss system. There's 5 categories, also based on clinical signs and symptoms. But something that they did draw attention to in the guidelines is that there's some individual variation in the clinical effects between individuals based on their core temperature. So some people may start shivering at a different core temperature than others, or may stop shivering. And so that may make it difficult to classify or differentiate in the Swiss system, for example, between class 1 and class 2, and which may be clinically important. And for that reason, among others, is why they want you to use their system. They also make mention of the American Heart Association 2010 guidelines, which again uses a slightly different classification that they recommend against, because the AHA is focused on when defibrillation may be successful, which is usually above 30 degrees Celsius, because below that temperature, defibrillation is often not successful. But for the WMS, they want rescuers to focus more on physiologic changes rather than specifically the effects of defibrillation. They also want you to keep your differential broad. And so they're recommending that when symptoms don't correlate with a measured core temperature, or there's a minimal history of cold exposure, but people are telling you the patient's hypothermic, consider alternative causes of their altered mental status, including sepsis, medications, drugs, trauma, or anything on our altered mental status differential. This is a schematic that's included in the guidelines. I'm not going to go into it in any great detail because I think it'll be covered both by me and by Vincent and others. I just wanted to draw your attention to the fact that it is helpful to have with you in the field. And kind of on the left side here, you'll see what I was talking about. They want you to use clinical signs and symptoms to categorize the patient. And so you're looking at their mental status, their shivering, and their consciousness, and that'll help you know whether the patient should be classified as mild, moderate, or severe. And so, yeah, this is the second half of the schematic with moderate, severe, and profound. Again, you're looking at level of consciousness, signs of life, and other signs of lethal injury as you're trying to differentiate between profound hypothermia and death. Another type of depiction that they also included was the cold card. And this is just another helpful tool to have with you to make decisions in a stressful environment. They depict your clinical signs and symptoms as a wheel here in the center. And then each quadrant is, well, in the top left it's not actually hypothermia, but it's cold stress. And the other quadrants is the mild, moderate, and severe hypothermia, and some initial treatments that you can begin based on your assessment. So as I alluded to, cold stress is an entity that is not necessarily hypothermia. So it's when a patient is briefly exposed to cold, often happens to someone who's normothermic and then suddenly gets submerged in cold water, for example, for a brief period of time, and then they start shivering. They haven't been exposed long enough to actually have a core temperature drop below 35 degrees Celsius. So they're not hypothermic, but they are cold stressed. And again, because you may not have access to accurate core temperature measurement in the field, there's some clinical signs and symptoms you can use to help guide you. So if a shivering patient is functioning well and they're able to care for themselves, they're likely not hypothermic, they're likely just cold stressed, and they can just be observed to make sure they're not going to deteriorate. However, if the patient is incapacitated, having any difficulty caring for themselves, then you should think that that shivering patient is in fact hypothermic, and you should treat them accordingly. Now, some recommendations regarding how to measure core temperature measurement. The esophageal probe is the preferred method per the guidelines, but it should be placed in a secured airway. So that is a supraglottic airway or an endotracheal tube, because there is a risk of aspiration otherwise. And an epitympanic thermometer with an isolating ear cap is something that should be used if you don't have access to an esophageal probe or you're not able to secure the airway. I should mention that an epitympanic thermometer is different than some of the ear thermometers that you see in normal clinic or whatever that are using infrared to look at the tympanic membrane. This one is actually using a thermistor or a temperature probe in the ear canal. And so that's why it's important to have an isolating ear cap, because if the ear canal is not isolated from the outside environment, or there's snow in the ear, or there's a bunch of cerumen in the ear canal, you may get inaccurate readings. Rectal temperature should not be measured unless the patient is in a warm environment because they have to be exposed to get that measurement. Furthermore, monitoring rectal or bladder temperature during rewarming of an unconscious patient is only recommended if you can't get esophageal or epitympanic monitoring, mainly because there's some lag when you're rewarming. They recommend against using infrared tympanic thermometers, oral thermometers that can't read below 35 degrees Celsius. So unless it specifically says it can read below that temperature, many times they cannot, and so they should not be used for diagnosis. And you should also not be using a temporal artery thermometer, which is just a skin surface measurement that also tends to be very inaccurate. They did make mention of something I've never heard of, that they said is a zero heat flux sensor, which is apparently an emerging technology that they just made mention of, but they didn't make a recommendation on because there's been no validations of it. But apparently it integrates a skin temperature monitor with a heat flux sensor or something like that. Out of hospital treatment. So like any good EMS or out of hospital care, you need to make sure the scene is safe. So they say you may not be able to make a decision to rescue or resuscitate until the scene is safe enough for you to make it where you need to be and make an evaluation of the patient. An important concept that they introduce is core temperature after drop, which is when the patient's core temperature continues to drop even after they're removed from the cold environment. And this happens from a combination of a couple of mechanisms. One is even after they're removed from the cold environment, you're still getting conductive heat loss from their core to the cooler peripheral tissue. So their peripheral tissue is still cold, and even as you're warming their core, as the blood circulates back to the heart, it's you're losing heat that way. The risk of after drop is increased by standing up, walking, putting a patient vertical to hoist them, any active or passive limb movement, or through warm water immersion. Again, all of these things do that because they're either, because they're increasing the blood flow from the periphery back to your core and bringing that cold blood. Circumrescue collapse is a related concept. It's a clinical phenomenon of lightheadedness, syncope, or sudden death that happens just before, during, or after rescue, most often after removal from cold water. It's thought to happen in part because of mental relaxation. So you're in survival mode and you're in catecholamine overdrive, and then suddenly you see your rescuers coming and you chill out, and that's thought to contribute to it, is that you have a drop in catecholamines that were keeping you alive. Furthermore, if there is water immersion involved, the hydrostatic pressure was keeping the blood, giving you venous returning. But now that the hydrostatic pressure is removed, you're getting decreased blood flow. And so your heart needs to compensate for that by increasing cardiac output very suddenly. But a cold heart is a fragile heart, and that can tip you into a dysrhythmia and you go into sudden cardiac death. Some key points that will help you to keep your patient from going into circumrescue collapse or experiencing after drop is to keep the patient horizontal, to limit the physical effort by the patient, and to avoid either active or passive movement of their extremities. And you can aid them in limiting their movement by cutting their clothes off once they're in a warm environment, especially if they're wet, rather than making them move their arms to get out of their clothes. You should encourage the patient, if they're conscious, to be attentive and focus on survival. That is the idea there being that you're keeping their catecholamines up as they focus on survival. You should handle them gently. Again, a cold heart is a brittle heart, so you're trying to not put them in VFib. And you should be using insulation and vapor barriers until the patient is in a warm environment. So insulation, anything from blankets, quilts, sleeping bags, vapor barriers, things to keep them from losing heat, both from convection and evaporation. And you should remove their wet clothes once the patient is protected from the cold. You should make sure to insulate the patient from the ground, heating pad or excuse me, a sleeping pad or something of that nature, and then cover their head and neck so they're not losing heat through that way. They do make mention of shivering being an effective method for a cold stressed or a mildly hypothermic patient to rewarm, but it is an uncomfortable thing for the patient, and there is a high caloric expenditure associated with it. And as the patient is shivering, they should be insulated from the environment to retain all the heat that they're generating. An alert shivering patient should be given high carbohydrate liquids and food. They do say that it can be warmed, just as long as it's obviously not hot enough to burn the esophagus, and as long as the patient is actually alert enough to not aspirate. A shivering patient who may be hypothermic should be kept warm, given caloric replacement, and observed before exercise. Again, you're worried that they have after drop, and so after you've given them a little bit chance to rewarm, you can see how they tolerate standing, and then increased exercise to help generate some heat. And if they start to deteriorate, you should stop and treat accordingly. They do recommend using active heat sources in conjunction with vapor barriers and insulation. They make mention of a product called the heat pack, which apparently generates carbon monoxide. So there's special precautions you need to take. You should only be using outdoors or with proper ventilation. There's something called the HPMK, which is the Hypothermia Prevention and Management Kit, which is issued to the military. And it's great because it's a self-contained little kit shown in the picture there. It's in a very small, lightweight foil contained package that can fit inside a backpack. It contains a heating element, a vapor barrier, and you can see on the patient, it makes a little hood around them. But they do say that it is great if you can augment it. If you happen to have a sleeping bag or something, that you can add an extra layer of insulation would be ideal. Body-to-body rewarming can be used in mild hypothermia if you have enough personnel available to do so, and most importantly, that it doesn't delay evacuation to definitive care. You should be applying external heat to the axilla, the chest, and the back using large external heating pads or blankets. If you can apply heat to the chest, maybe they're having CPR ongoing, they have some sort of chest trauma that precludes you from doing it, then you can apply it to the upper back or head. Just make sure that if you're applying it to the back, that you're still able to observe them, you're able to roll them or whatever to observe their back and make sure they're not getting thermal burns. You can also apply it to the neck, as long as any neck openings is not allowing heat loss. And they do say that you should avoid applying heat to the extremities. Again, as we mentioned, the physiology there is that it can contribute to after drop. You should avoid local pressure to cold skin because it's highly sensitive to injury, and you should be applying your heating elements per the manufacturer instructions, which usually includes having some sort of thin insulation layer between the heating element and the skin so as to minimize the risk of burns. You should be reassessing the skin every 20 to 30 minutes for signs of redness or other signs of impending thermal burns. You should not be using small chemical heat packs, which are usually known as toe warmers or hand warmers, because they're not going to be effective. They're not going to contribute substantially to core rewarming. However, they can be used as intended and as advertised to prevent local cold injury, such as frostbite to the hands and feet during evacuation. Heated humidified oxygen can be used in conjunction with other rewarming methods, but you can't rely on it as the only rewarming method just because your respiratory tract doesn't really have the capacity to get the rate of heat transfer that you would need. And so you shouldn't just be using it alone. You should not be using a warm water shower or bath for initial rewarming. Once again, this is due to the after drop phenomenon. If you were to do this, you would cause the peripheries to vasodilate and they'd get hypotension and circumrescue collapse. However, they did go on to talk about something called distal limb warming, which I didn't fully understand how it was different than warming the extremities, which back here they said avoid applying external heat to the extremities. But basically they described it as immersing the arms and legs up to the elbows and knees in warm water, 42 to 45 degrees Celsius. And apparently the physiology there is that it opens arteriovenous anastomoses and can be helpful in mild hypothermia in the right clinical settings. But since I don't know much about that, I would be very wary of doing that because it sounds a lot like some of the things that you should be avoiding so that you're not causing after-drop. They make a recommendation for forced air rewarming during ground and air transport. Ambulance patient compartment should be heated to at least 24 degrees Celsius. So it's said that the temperature at which a unclothed resting human will neither gain nor lose heat is 28 degrees Celsius, but they acknowledge that 28 degrees Celsius is uncomfortably hot for anyone who's not already hypothermic. And so your attendants to the patient, whether that be the crew or the medical staff that are in the ambulance, might have a performance decrement if you were to keep it 28 degrees. So they just recommend as a minimum, try to keep it at least above 24 degrees. And a cold stressed patient, again, someone who's shivering, but not with a core temperature below 35, is at a low risk of after-drop or circumrescue collapse. So you don't need to take some of the precautions that we're talking about. You don't need to worry about keeping them horizontal. You don't need to make sure that they're not standing up or moving their arms. They're allowed to do all those things. All righty. I think I breezed through that. There was a lot of stuff, but we're on to part 2, and I think Vincent will pick up.
Yeah, let me go ahead and share my screen. Let's see, are you guys seeing a PowerPoint? Yep.
Yeah, looks good.
All right. So I'm going to be presenting part 2. My name is Vincent Costers. I'm a second-year emergency medicine resident at the University of South Florida. So I'm going to pick up with the resuscitation of hypothermic patients. It's going to hit a few categories here with that: when to resuscitate, recommendations for CPR, recommendations for defibrillation, what to do about an airway, circulatory resuscitation, and then talking about dysrhythmias, drugs, and glucose and other adjuncts. So when to resuscitate. So hypothermic patients are a little different than other patients. A normal patient, you might get into a trauma bay. If they have fixed dilated pupils, they seem to be in rigor mortis or have dependent lividity, you might just say they're already dead, there's no point. However, with hypothermic patients, you should still continue to resuscitate these patients. That being said, if they have obvious fatal injuries, like there's exposed brain matter, the chest wall is too stiff for compressions because they've been outside for days, that sort of thing, then obviously don't resuscitate. As far as CPR, the first thing you want to do is try and move them to a warmer place if possible. Most of the issues with the cardiac dysrhythmias and the reason you're not having a perfusing rhythm is due to having too cold of a heart. So you're going to be fighting yourself if you're trying to do CPR in the cold. However, you shouldn't stop that from starting CPR if there's not a quick way to get to a warm place. You also shouldn't go off of the core temperature to decide whether or not to start CPR. Like I said before, only if there's some sort of injury that's fatal on its own should you not do CPR. And then if the patient has QRS complexes on the monitor, whether that be PEA or not, you should not do CPR unless you also have end-tidal CO2 monitoring that shows that there is end-tidal CO2 coming out, meaning that there's some perfusion going on. However, the QRS complexes can be very small and hard to see on a monitor. So make sure to go ahead and use the maximum amplitude you have on that monitor because you're going to have kind of a global low voltage situation with the hypothermia. So there's some studies done on intermittent and delayed CPR in hypothermia with some good neurological outcomes. However, you still want to try to do CPR as soon as possible. Immediate CPR is the ideal situation. However, if you do have to delay it, don't delay it more than 10 minutes, if that means getting to a warm place with the person. And if you're going to be doing intermittent CPR, like as in a situation where you're trying to transport somebody to a warmer place while continuing CPR, that might be more than a few minutes away. Do at least 5 minutes at a time and leave less than 5 minutes between the rounds of CPR. CPR rate's going to be the same as your basic ACLS algorithm, 100 to 120 per minute. And then if this is a prolonged situation to get somebody to a final destination of care, you may want to use a mechanical compression device if you have that available to you to keep the rescuers from getting too fatigued. As far as defibrillation, if it says advise shock, for example, a VTAC, VFib, go ahead and give that shock. However, if they're still below 30 degrees Celsius, as far as a core temperature, you only want to give one shock, because if it doesn't work at that time, likely it's just due to the temperature of the patient itself. But once you get above 30 degrees, you can keep going by the ACLS guidelines. And every time you do a rhythm check, if it says shock, go ahead and shock. There were a few case studies in the past that have shown that a patient who's hypothermic has a very sensitive heart. So when you intubate, that extra stimulation can cause VFib. However, that's very rare, and you should always still go for the definitive airway in severe hypothermia to help resuscitate the patient. Along with that, you want to go ahead and drop an NG or an OG tube to go and decompress the stomach. And then whenever possible, use end-tidal CO2 to monitor the patient. Just in general with CPR, whenever possible, use end-tidal. It can tell you whether you're giving good compressions and kind of monitor a circulatory and perfusion status of the patient. And then keep in mind that end-tidal CO2 that is normal is going to be different at different elevations. Okay, so make sure to review those charts to make sure that if you're at altitude, what a normal end-tidal CO2 is. And then as far as a circulatory resuscitation, if you can't get a peripheral IV quickly, go ahead and get that IO. IO can be used for just about anything. And if for whatever reason you don't have a way to get an IO, then you can use a femoral central line to get access. Peripheral IVs can be difficult in hypothermic patients because all of the peripheral vessels are clamped down. And then a lot of these patients, they may have a falsely low circulating volume. So fluid will help initially, but as everything starts to reperfuse, you can also overload these patients with fluids. So you want to be careful and not give too much at once. And then you want those fluids to be warmed whenever possible. Another thing that was pretty interesting is rather than putting them on a constant drip rate of fluid, just go ahead and bolus them and then turn it off. The reason being is as fluid is hanging, it's getting cold and everything in the line is getting cold as well. So you're kind of fighting yourself there. As far as resuscitation drugs, in hypothermia, your metabolism is a lot slower. And because of that, you want to use smaller doses of things like anesthetic agents and paralytics because they'll last a lot longer than you think because they're going to be metabolized slower than in a normothermic patient. And then at altitude, you want to give supplemental OT. And if a patient has glucose derangements for hypoglycemia, you do want to go ahead and give glucose. For hyperglycemia, there's no reason to give insulin. Talking about dysrhythmias now. There is not a lot of evidence so far in hypothermia and using pressors and other antidysrhythmic medications. It was found, though, that below 30 degrees, you shouldn't give pressors at all. And that's, for example, like in an ACLS, giving epinephrine at the 2-minute marks. Between 30 and 35 degrees, though, once you get over that hump, you can start doing normal ACLS protocols. And then if a patient is bradycardic and they're hypotensive and it's not really matching completely with just the hypothermia, there may be something else going on, go ahead and use the transcutaneous pacing like you would with any other patient. And then as far as AFib, flutter, any of those atrial dysrhythmias, no need to treat those. So then talking about transport and triage, I'm going to talk about on-scene recommendations, when and where to transport a patient, and then one little thing they mentioned about biochemical markers. So for hypothermia, you want to be rewarming from the start and continue that rewarming all the way to the hospital, rather than just doing an initial rewarming or doing a delayed rewarming. Whenever you can, keep it going and limit the exposures to the cold. And then just like any other transport, you want to get any spinal injuries stabilized, whether that be with a C-collar or a backboard or whatever it may be, depending on the injury. And then you can go ahead and relocate dislocations or reduce fractures if that's easily possible, but you shouldn't let it delay your care. And then cover any open wounds that might be letting out more heat. So if you have a patient who's uninjured, they're shivering, they're completely alert, that's not a patient that needs to go to the hospital. You can give them some care, but they don't need to go to the hospital. The more moderate to severe hypothermia, but that is not critically ill, can go to any nearest medical center. But then the patients that are either in cardiac arrest, they're hemodynamically unstable, or their temperature on a core reading is less than 28 degrees, you want to try to get to a center that can do ECMO or other types of extracorporeal life support. If it's going to take you more than an hour extra to transport that patient, then you want to go to the nearest medical center first for a stabilization, and then go on from there for a transfer to a center that can do ECMO. And then any trauma patient still goes to a trauma center. And then they gave a mention based on past cases and what the highest potassium level that ever got resuscitated was and still survived. It was like 11 point something, I think. And then they found out that it was probably an error because they did a repeat and it was like 4 or 5. If the potassium is greater than 12, there's never been a case of anybody living. So you can go ahead and call it at that time. And then kind of a key takeaway, I think the thing I saw in the guidelines that was most useful was this cold card. And we're going to hear more about it in a little bit. But I think if there's one thing you remember, or that you could have like a picture of on your phone, that'll kind of help you triage and figure out how to at least get started with taking care of patients with hypothermia, I'd say it's this cold card. All right, and I'll leave it open for any questions.
Any questions or comments on either half of the guidelines?
All right, and then I guess we'll move on.
All right. Well, thank you both. I know that was particularly a dense set of guidelines. It's one of the longer ones. So the next 2 articles will kind of expand somewhat on the field and the transportation and in-hospital management. Ben, since you've got to go pretty soon, why don't you take it away? I don't want to delay you here.
Okay, sounds good. Let's see if I can screen share here. You guys see that okay?
Looks good.
Okay.
You are in like the not presenter mode with the things on the side, as long as you're cool with that.
If I do anything else, I might mess it up.
Looks great.
Perfect. All right, so I'm covering the article "Human Responses to 5 Heated Hypothermia Wrap Systems in a Cold Environment," and this was published in the Journal of Wilderness and Environmental Medicine in 2019. And my name is Ben Speck. I'm a paramedic and a second-year PA student. So this was published by a handful of people, Ramesh Duda, and I'll probably butcher that name, and colleagues out of the University of Manitoba in Winnipeg, Canada. I don't know much about this group, but I'm assuming that this is a pretty reputable site, and they do a lot of laboratory and exercise medicine. The goal of this review was to compare 5 different heated hypothermia wrap systems, and we'll go over some images to kind of throw those up there just in case anybody didn't read the article. So the way this study was designed, they only had 5 subjects, so very small sampling, one of which was a female. These were volunteers that were recruited from the university. They were all healthy, active, and they had no cardiorespiratory conditions, nothing that was going to be exacerbated by a cold environment, so all relatively very healthy people. All of the 5 different systems that were studied all had some type of enclosure system, a vapor barrier, and a heat source. The 2 heat sources were the dry chem packs, similar to like your hand rewarmers, and then the gel packs. If anybody's ever used those before, they're just a gel pack, but they're quote unquote rechargeable because you can reheat them and use them again, unlike the dry packs that are just, open them up and then pitch them when they're done. So the different systems that were used, starting with the first one, this was the only non-commercial one. This is a user assembled model, and their user assembled model was a mid-weight sleeping bag. It was a 3-season sleeping bag that also contained a internal vapor barrier. And then they used 3 gel packs as their heating source. The last 4 were all commercial devices, including the Dr. Down rescue wrap, the HPMK that I believe Dan kind of showed a picture of. That's the more military based product, very small, compact, comes with a bigger price point, and it's single use only. Then the Marsars hypothermia stabilizer bag and the Wiggy's victim casualty hypothermia bag. And each of these different scenarios that they ran these patients through, they dropped the temperature down to a -22 degrees Celsius, and each participant was in the different system for up to 60 minutes. And then they had continuous feedback, both subjectively, and then they had a bunch of different objective ways to record data. So if you didn't read the article and you've never seen these products before, I figured I'd throw this up there. Over here on the left, this is the Marsars product. You can see it's the largest of the 5, and they actually added some commercial price points. So this one comes in just over $500, very large. This over here, this is your typical user assembled sleeping bag. So this is a good reference point for size comparison. But imagine if you're kind of building a loadout for a mission or some kind of trip, very large device over here. Next one's the Dr. Down. This is the Wiggy's. This again is the 3-season sleeping bag, and then the HPMK. So a much smaller device. It's still pretty large for somebody to pack in a single loadout, but it does have a lot of benefit to it. And then of course the cost at the bottom here, obviously the user assembled was the cheapest overall because it's user assembled and it has multiple purposes there. So as far as the evaluation, like I said, they use a couple different metrics to evaluate the subjective feedback. Throughout the study of the subjects, they were asked to rate their overall comfort every 10 minutes on a 0 to 10 scale on their whole body cold discomfort. So every 10 minutes they said, hey, how cold are you? And then at the very end of each 60-minute trial, they had the subjects rate their overall temperature subjectively from very warm to very cold. And then they got to rate their system preference from least preferred to most preferred. So very subjective in that terms. Then when it came to the objective analysis, they had a handful of different ways they actually measured heat within the systems. So the first one was through these 12 skin site monitors with temperature probes, and they were fixed to various parts of the body to actually measure the body temperature just on the skin, not no invasive temperature probes. They also measured metabolic heat production, respiratory heat loss, and then they used those metrics to look at the net heat gain that was calculated from all of that. So as far as the results, the first metric that they looked at was the heat pack surface temperature. You can see in the graph here all the different systems that were measured. The gel packs, if anyone's familiar with those heat very quickly. So those products here heated to the highest temperature first, but then quickly drop off. So any of the systems that they use a heat gel pack, you start with a very high temperature, but over time, even in a vapor-proof insulated system, they lose heat really quickly. Again, the benefit to the gel pack is you can quote unquote recharge it. If you have like a jet boil or some type of water system that you can heat, you can throw a jet pack in there, reheat those packs and put them back in your patient cocoon. And these other ones here on the higher end, these are your dry chem packs. So you can see there, it takes longer for a dry chem pack to warm to the optimal the temperature, almost an hour or plus. You can see here as it kind of peaks here in height at about the 60 to a 90-minute mark, but then over time, it maintains your temperature for much longer. So the patients reported higher temperature throughout with the dry chem packs. The other measures that they used were the core temperature and the metabolic heat production. You can see both of those depicted over here. The top one being the core temperature. And as far as results go, the body temperature started at baseline. Obviously, all the patients were normotensive, normothermic at the beginning. And then over time, you can see each of the different systems displayed differently. The HPM and the HPMK showing the worst overall temperature loss, and the best one coming from the doctor down system that maintained actually an elevated heat system here. The other metric they used was the metabolic heat production. And again, there was no difference in the first 30 minutes. You can see all the systems had a net loss in the first 30 minutes. But as those heating elements started to kick in, the HPMK system actually had the best overall metabolic heat production because it maintained a good, strong vapor barrier. And that dry chem system was able to add to the heating system itself. But huge spread between all 5 systems measured. And then the last metric that they looked at was the net heat gain. And statistically, there was significance for condition, time, and interaction during the first 30 minutes here, where they all had a net heat gain. But then after that first 30 minutes, they all dropped back down. The only ones that maintained the same heat throughout were the doctor down and the user assembled, ironically. The other commercial products all had net heat loss. And then for the subjective evaluation, when they actually had the subjects rate their overall experience, across the board, all of the users actually said the HPMK was a much colder system as compared to the others. But the big takeaway here is that there was no significant difference detected for shivering rating and preference rate. As far as their conclusion from the study, they did use 5 similar systems, but they all had their unique differences. These are all options for hypothermia care and for management, but they all have a couple different issues. Cost and footprint being the biggest one. The size of having to pack that kind of system wherever you're going could be a huge burden. The user assembled and the doctor down systems had superior physiologic performance when it came to the objective measurements. They had higher total body temp and net heat gain, and they had no report of heat loss or shivering from the subjects. And then during the 60-minute evaluation, core temperatures did not drop with any of the systems, indicating that really any of these systems would be effective based on that type of situation. As far as my kind of thoughts and review of the review itself, yeah, this is kind of a small subject group. There's only 5 people. These are all healthy, non-injured people that they're studying in a very controlled environment. They're all very healthy, which would be kind of similar to any other hiking expedition. Most of our hiking group people are a healthy population. But again, that's only 5 people, and it's from a small college group. They didn't factor for any injuries. So it would have been nice to have data on injured patients, any type of patients that have already had heat loss through trauma or other means, maybe just being exposed to the cold. But I think it is a good article for anybody who hasn't seen a lot of these products, just because it does introduce you to a lot of the different products that are out there, especially if you're trying to do any kind of planning or mission set, looking at different options out there. I think at the end of the day, understanding the components that you would need to improvise some type of user assembled model is probably one of the good things to just keep in the back of your mind. Using what you have, using something that has multi-purpose to it, and being able to build a user assembled system if you don't have a commercial kit available is pretty important. So I think it's a good article overall, but definitely some issues with it.
Ben, what do you think like a next step or like a branching off article could be? Or like, sorry, project study.
I think it'd be interesting to see some data on actual patients rather than just controlled subjects, but that would take a lot of effort to get that data. I think we have a lot of data on patients that arrive to facilities in their initial body temps, but there's not a lot of data out there on injured patients in these different systems already. The only one you'll probably get a lot of data from is the HPMK because it's used in the military and there's so much data collection through the military. But again, 5 subjects is pretty small, so that it's kind of just it's nice to look at, but it's not great.
Yeah. Somebody other than Ben, what would like your main takeaway be from, or maybe like your change in practice when you're going out into the wild, what you bring with you? Anybody? I'd say for me, basically, I think it pretty much shows that if you have your own gear, you've got like your own tarp, you've got your own vapor barrier, you've got your own heat packs, a good sleeping bag, you can pretty much compile your own system that you would have with you anyway. And why bring all this bulky, heavy stuff when you have appropriate gear with you, or use patient stuff first, use their sleeping bag, use their tarp, use their, they might not have warmers, but I think it shows that you're not going to have deficient care by using stuff that people have with them anyway. You don't need to buy a $900 Dr. Down when you can make your own thing.
That was my biggest thing. It's like, I'm wondering, we have a dude that did kind of race support stuff and had a Dr. Down, which he gave to us now that we're doing all of the support. But I've just been running around with a sleeping bag and a tarp wrapped around it and some rope to make like a litter. And this tells me, and I was like, oh man, maybe I should throw an HPMK inside my wrap, but it's maybe not necessarily worth it. Like the self-built thing is actually pretty dang good. Like, right, it was really, really close to the Dr. Down in terms of insulating value. So for me, that's kind of like a big takeaway, to be like, what I have and like what we're doing and what we teach is it's actually pretty good. It's not like we're just teaching people this and we're going to find out, after this study or some other study later that it doesn't work.
Yep. Plus it saves like $1,000 and you're not carrying something extra.
Yeah, I thought about buying like an HPMK or the Dr. Down, but that thing's like $900.
Be interested to do it with some other materials. So if you were on a trip and maybe only had like a thick trash bag or something like that, doing the same thing with a jacket and a thick trash bag to see how inferior that is to actually having the sleeping bag and things. So maybe looking at some of those, maybe wet down versus dry down. So, if you're in a bad situation, usually lots of things are going bad. So is it better to put them in their wet down sleeping bag or leave them in a dry down sleep, in no sleeping bag? So I think there's just some kind of interesting takeoffs you could do from a study like this that would be pretty easy.
Yeah, or the synthetics. I think because again, we're thinking about being in the austere environment. Like I usually have an old synthetic bag that I put in the kit. Be kind of cool. Is it worth getting it down or taking my down? My down's expensive. I'm not going to plan on putting some grody patient in it, but maybe I should.
Yeah, I think remembering too that these commercial products have one purpose only, and trying to select things that have multiple purposes, especially if you're trying to stay ultra light wherever you're going, even if it's a very extended amount of time. Even dropping the gel packs and the dry chem packs, you could easily heat up some water on a jet boil and put it in an Nalgene and use that as your heating source to keep it warm. Just thinking of renewable energy in that way. But again, yeah, emergency foil blankets that are the size of a wallet are your vapor barrier. Those work great. They're disposable, they're low footprint, they're super light. But yeah, I think it's all based on the mission, the objective, wherever you're going, what you can carry, how many people you have to distribute the weight. But all good things to consider.
Justin, you're still muted.
That's the main reason I chose this article. Basically make you realize you don't need this crazy stuff when you can multitask and have your own gear or the patient's gear and use that. Any other questions or comments on that? All right, well, thank you, Ben, and glad we got you in before the 8 o'clock hour there. Kristen, you want to take it away with our last article?
Sounds good. All right, so the article that I have is Hypothermia Outcome Prediction After Extracorporeal Life Support for Hypothermic Cardiac Arrest Patients, really evaluating the HOPE score. So this was an international collaboration led out of Switzerland Emergency Department. It was published in 2018, primarily kind of looking at European data. So I like to kind of start this off with what is our clinical question that this article was trying to answer, and I'm putting this into our PICO format, so it's a patient intervention comparison outcome. So in patients who are primarily hypothermic cardiac arrest, who undergo rewarming with ECLS, does using the HOPE score as opposed to using a potassium level alone better predict survival to hospital discharge? And so kind of the bottom line with this is that, yes, the use of the HOPE score is a better predictor of survival than using potassium alone. And ultimately, this would have reclassified 27% of patients, avoiding 1 in 4 futile ECLS rewarming attempts without losing a single additional life. So breaking this up into kind of each of our components. So the patients that they chose were patients that were chosen to be placed onto ECMO or cardiac pulmonary bypass. And this is a very resource-intensive technique and procedure, and it's also very invasive. So I think it was kind of a good kind of patient population to choose, as these are some of our sickest patients that are really undergoing pretty extensive kind of interventions. So our intervention, so the authors created this HOPE score, and they looked at several different criteria, including sex, age, potassium level, core temperature at admission, duration of CPR, the modality of rewarming, whether it was the cardiopulmonary bypass or the ECMO, and then the cardiac arrest, the initial rhythm at hospital admission, and then the mechanisms for hypothermia, whether it was asphyxia related or non-asphyxia related. And if you go towards this website, you can find the score that they used and how you can put in different data, and it'll give you kind of your outcome and your prediction. If you wanted to do the score by hand, you can find that in the article. The comparison is using a potassium level alone. Now they chose 12 as their cutoff. And as you heard previously, that's kind of a known, kind of above 12, really kind of not compatible with life or kind of with resuscitation. But more interestingly, potassium of 3.5 had about a 70% chance of survival, as opposed to one that was 4, where there's 59% chance, or a potassium level of 6, where there's a 30% chance of survival. As you all know, a high potassium level is indicative of cell lysis, hypoxia, as well as the duration of cardiac arrest. And a lower potassium level can be seen due to some metabolic slowing, pH, or the beta-2 adrenergic intracellular shifts that take place, as well as hypothermia induced kind of membrane stabilization effect. Our outcome that they looked at was predicting survival to hospital discharge, and kind of the secondary one that they discussed briefly was is there a good neurological outcome at time of discharge? They chose to use the cerebral performance category scores to define a favorable neurological outcome. And I think when we have our outcome, our big thing that we need to think about is this a patient-oriented outcome? Is this something that our patients will care about? And yes, patients generally tend to care if they, live and survive. But I'm glad that they also included the neurological outcome because that's the other really key component that patients care about is, are they going to be able to go back and kind of do the things that they love and enjoy doing? So why is this something that we should be looking at and studying? So it is a topic where we want to avoid kind of undertreatment as well as overtreatment. And when you have patients that are very critically ill, it can sometimes be hard to know, which way a patient's going to go. From a mass casualty standpoint, this can be useful because, ECMO machines are limited. And, if we are able to better predict who is going to have a good survival and a good outcome, we're hopefully able to better utilize our resources in triaging these patients. And then finally, it does help with counseling families and setting realistic expectations. And it's something where you can provide a little bit more kind of concrete kind of data to people when they're kind of experiencing really difficult situations. So for this article, the authors decided to do a systematic literature review as well as using some unpublished hospital data. They ultimately were able to get 237 patients from the literature review and then 49 patients from the hospital data collection. And there really was no major difference between these two groups. So this is considered retrospective and kind of a mixed study design. They were independently and blindly assessed for bias by two of the authors, and then a small percentage of the data extraction was cross-checked for discordance. They did not use data such as like case series or like individual like cases for analyzing this. So looking at the results, so they did find an association of 6 of the independent predictors, the sex, asphyxiation related mechanism of the cardiac arrest, age, the potassium level, CPR duration, and temperature. They did not notice any difference between witnessed versus unwitnessed cardiac arrest. And so you can see in this table the sensitivities and the specificities, PPV, NPV, false positives, false negatives for kind of their different criteria. And so I think that this is interesting where they kind of show both the potassium of less than or equal to 12 as well as less than or equal to 8. And the 12, as we mentioned, really nobody's going to survive when it's kind of greater than 12, or at least nothing that's really been reported. But then looking at even something like a potassium level of 8, while our specificities have increased to 23% and our sensitivity is 99%, essentially 100%. But there can be a little bit more in the false negatives with that. And then kind of using the different kind of cutoffs for their HOPE score criteria. And so ultimately the authors chose the 0.1 as their cutoff. I think that was primarily due to kind of that false negative and not having anybody in that false negative category. However, we can kind of discuss a little bit later on of, is that really the best kind of, measure to use, or should we be choosing, kind of one of those different cutoffs? And I think it's nice that they did give us the values for those different cutoffs if we were to choose, to use, 0.05 or 0.2 or whatever we'd like that cutoff to be. So here is a little figure that they created, essentially illustrating what we just talked about. So when you have your potassium greater than 12, so of these people that were, experiencing ECLS, 5 of them had a potassium greater than 12, and as expected, they did not survive. However, when we're using the HOPE criteria, and if we get a value less than 0.1, that shows 32 of these people, so essentially an additional 25, 27%. We could have correctly said, okay, these people were not going to survive and therefore may not be the best candidate for ECLS. We still are collecting all, that 37% of those that would still have that good outcome. However, there's still a significant, essentially almost a third of patients where we'd still could put them on the ECLS and they still would not survive. Here we can look kind of at our receiver operating curve and kind of seeing how, our area under the curve for the HOPE score, is higher than for our potassium. And same thing over here with our graph where we're kind of looking at kind of the percentiles in terms of kind of the survival, and really seeing kind of a pretty significant difference between, kind of the score and probability with our kind of good outcome. And so this is where, you could look and say, okay, if I chose that, 0.4, I'm still collecting, kind of, most of the patients and, kind of utilizing, the ECLS less. However, again, we are going to be missing more patients that potentially would have survived and had a good outcome. So the conclusions of this was, out of the patients that they analyzed, 37% did survive. 84% had a good neurological outcome, which is actually a pretty, at least in my opinion, a pretty good amount to have, a favorable neurological outcome. The final score, as we mentioned, kind of uses these different variables of age, sex, core temperature at admission, serum potassium level, mechanism of cooling, and cardiopulmonary resuscitation duration. And, again, it would have reclassified 27% of patients, avoiding the 1 in 4 futile ECLS without losing a single additional life. So strengths of this article is that it's kind of a more robust data than just the case reports, case series, and experts' opinions that previously contributed to kind of that standard of care of using that potassium alone, or really where most of the focus had been. I think another important strength is that this limits clinician bias, and it limits bias both in both ways. One, where we sometimes can think about our patients that are undergoing cardiac arrest, like in hospital cardiac arrest, who have other multiple disease processes going on, where their survival and or neurological outcome might not be as great as it is when they're coming in hypothermic. However, it can also limit our bias where when we have somebody who is experiencing, kind of higher potassium levels, really is not a candidate for, or kind of otherwise would not make it, despite ECLS helping us with that decision of not initiating the ECLS kind of measures. Ultimately, this is allowing us to use our resources wisely, as well as helping with counseling our families and setting those realistic expectations. Some limitations, or really some considerations. So when we're looking at the study design, it is retrospective. It would be unethical to perform a randomized controlled trial. Doing a prospective study would take a long time to get enough data. So I think, how they did a retrospective kind of study is definitely appropriate for kind of looking at this event. At the time of the publication of the article, there's no external validation. However, I believe the next year, the same authors did do a validation that was consistent. But again, it is, with the same authors. Overall, this is a pretty rare event, which does lead to our smaller population size, as well as the heterogeneity of the different studies, since we're getting several different studies from, I believe they just kind of small patients of lots of different studies to get a large enough kind of pooled population. So that would be, kind of, is there other confounding factors on, how they used ECMO or other, factors that contributed to the survival of certain patients. I think another big thing is that these are the group of patients that were started on ECLS. And so this does not take into account all of those decisions that were made earlier in terms of, is this patient, so sick, or kind of has other things that led the clinicians to not, start ECLS to begin with. And therefore, this could be an overestimation of their survival, since, again, those sickest were not included. Then I think we've kind of already talked about kind of those other confounding factors that we just don't know about yet, or haven't contributed, that could also be influencing, the survival of patients. So applying this to our patients, so from my understanding, this did include data from non-wilderness-based patients. So for example, patients that are experiencing homelessness or other things. In the validation of the HOPE study, they specifically noted kind of like the proportion of avalanche victims was low. And so, kind of these specific subgroups that we might be experiencing out in the wilderness might not be appropriately kind of represented in this score, and therefore may have different outcomes. CPR duration in the wilderness can be very difficult. And so does that play a role in the HOPE score and kind of how you categorize kind of the CPR duration in utilizing the HOPE score? And does that change our outcomes? This is not intended to be a tool used in the field to predict survival. So it really is kind of just limited more towards the hospital setting. We kind of already mentioned about using different cutoff values other than the 0.1. I think that the 0.1 is a very reasonable, again, so that we really are giving all of our patients, or at least a pretty significant portion of our patients that have a decent chance of survival, kind of that opportunity. However, when we're looking at, say, more of our children or elderly, or kind of our different, kind of patients in that realm, could this be different? Or could this lead us to choose a different, cutoff value? Would, kind of just be by the fact of somebody being a child, would we choose maybe the 0.05 or something else? And that kind of goes in towards the extrapolation in terms of extremes of our data. And I didn't really see kind of what our extremes were in this data set, which I think would be interesting to kind of know at what point are we really kind of going above what this data looked at, so that we can kind of take that into our consideration, because ultimately our clinical judgment is still kind of the ultimate deciding factor. If we're missing data, of course, when applying this to our patients, that can make it a little bit more challenging. But again, I think ultimately this is more of a tool in addition to kind of our clinical judgment and the other factors that we're seeing in helping us to make this decision, and probably shouldn't in and of itself be the sole and only kind of deciding factor in deciding whether or not to put somebody on ECLS. So with that, would you utilize the HOPE score in your hospital?
Hey, CJ, there you are.
Yeah. I definitely would use the HOPE score in my hospital, and I have used it at a critical access hospital. I'd also be a little bit hesitant to call the restriction of not being able to use it in the field, especially as ISTATs make their way into the field, and like some especially austere rescue teams will carry them. They have they're kind of hard to use sometimes in the cold, but there's actually, I believe it was an MRAP recently, somebody presented on having used the ISTAT and used the HOPE score during an avalanche resuscitation. But yes, I have in fact used it to convince a cardiothoracic surgeon from a big academic center to fly over to the critical access hospital that I was working at and cannulate at the critical access hospital.
And Kristen, like you were saying, in medicine, there's quite a few like scores. There's PERC, Wells, Heart score, HOPE score. And like you said, you don't use that as your sole deciding factor. You use that to support like your gestalt and your results and your evaluation and experience. So you don't base your whole care on this, but you can use this score to kind of support your case when you're discussing this with an ICU doc, with a cardiothoracic surgeon, and just to kind of second check yourself. Like, this patient CPR lasted this long, they're this age, this is their potassium, and the other parts of the score. And all right, cool, let's do it. Let's get all this transfer started. Let's do all this next level effort. But yeah, it should never be like your sole deciding factor.
It's kind of a cool thing to have in your toolbox. And if you ever had like hypothermia patient, like there's kind of this funny spot where everybody like realizes like, thinking about, I've seen a number of times people are like, oh, they're going to call the patient, they're going to call him dead. And they're like, oh gosh, wait, he's cold. Okay, he's not dead until he's warm and dead. Okay, crap. Now what do we do about it? And the hyperkalemia is kind of an out, but as you've seen, as the like guidelines have sort of creeped up, and it used to be, it was like 8 and then 10 and now maybe 12, even though that might be bogus value. When you actually have to warm them up to declare them dead, that becomes this like crazy feat of either cannulating or convincing maybe more difficult CT surgery folks to come cannulate, or trying to warm them up through the rest of the like heroic means, which turns into a like 5-hour ordeal. When you're doing CPR for 5 hours, this becomes another way to say like, okay, maybe this is sort of hopeless. So I like kind of think about it like it's kind of cool because it gives us another like sort of tool to say like to advocate for getting ECLS in the patients that need it. But the purpose of the study, and where it's actually kind of more useful, is how else can we have an out, right? This is if you set that cutoff of 10%, essentially, or 0.1, then you can say like, look, okay, the potassium's 6, but this guy's got a chance of like neurologically intact survival at like 2%. Like, this is probably not gonna be a worthwhile use of all these resources. So it's definitely better than what we had.
Nothing.
Which was a potassium and
yeah, we'll
yes,
see.
or deal with it.
So I don't want to delay you too much because we are going to work through this case, and there's a lot of slides in the case that are integrating everything we just talked about. So it is going to move faster than when we've worked through this case in the past. But just one thing I wanted to mention real quick: why do you guys think that avalanche was specifically mentioned as something that might not be the perfect application of the HOPE score? And Kristen definitely touched on this.
Death. It's a asphyxia death, theoretically.
Right. For the most part, death is going to be from asphyxia. And then if there's another alternative, it's probably asphyxia. And if it's a third or fourth alternative, I guess it might be trauma. So, or like another medical problem, but it's essentially asphyxia, which is not the best outcome for a hypothermic patient. So that's, from my takeaway, what the main reason they don't use it for. So the guidelines in the 2 articles we just talked about are going to be implemented in this next case. Anybody feel free at any point to jump in. It's student-led and a student intended case. Our fellows put this together. It consists of like a pre-hospital, an EMS, and an in-hospital portion. And I've been speaking with a few people who have elected to help with each segment. So my wife just brought me dinner. So what I want the people who are helping me to do is sort of each segment to sort of hand off or give a report to the next group to kind of summarize how you would in real life. So we'll work through this as a group, and I hope for good participation. And if you could turn on your videos, I think that might kind of make this seem like a more team-based effort. I'm going to share my screen since I have the cases up. One of our fellows is online, and if he's not getting a call, because I think he's working an observation shift right now, then he might be able to help me out with one portion of it. But I'm going to share my screen and pull up the presentation here. All right, can everybody see this? It's kind of a snowy background. You don't see it? Thumbs down? Thumbs up. All right, let me just put it into screen share mode. I don't use the Google Slides all that much. All right. So you're part of a search and rescue squad. Don't worry about the dates, but we'll call it today. The call comes out at like 8 in the morning. It's the spouse of a 45-year-old male calling, saying that her husband went out for a 4 to 5 hour hike yesterday evening, never came back. Found this when she woke up this morning, realized that all of his gear and car were still gone. No signs of him having come home. He typically brings a pretty well-supplied pack with him, but she doesn't actually know what's in it. He thinks he probably has enough water. His plan that she heard of was that he was going to start a 5-mile section hike of the Appalachian Trail here in Virginia. He thinks he might have had good cell coverage, but she has attempted to contact him and hasn't had a response. Weather reports are showing an unusually heavy snowstorm that hit last evening. Your instructions are to proceed to the patient's last known location. There will be a truck meeting you with additional gear at the trailhead, and that's available for any supply requests. So let's say you get to the trailhead. I feel like something's not showing up. Oh, there we go. So you get to scene. What's the first thing you do in any search and rescue op? You arrive on scene.
Make sure the scene is safe.
Yes, yeah. No additional patients, please. So scene appears safe. No imminent like falling debris. Temperature is cold, but you appropriately dressed and have your appropriate cold weather gear. It's kind of cloudy, so no direct like sunburn risk, which in snow conditions is actually highly likely, and no like significant slope that you're going to fall down. So do you think this patient's going to be able to give you consent? Always think about it, but let's say this patient's nonverbal right now, can't really give you consent. Does that mean it's implied? Yes. Patient's unresponsive, implied consent. So does anybody know what MARCH stands for? Or has anybody done advanced wilderness life support or any wilderness EMS training?
Massive hemorrhage, airway, respiration, circulation. I forgot age.
That's okay. There's one pertinent part for this case. So hypothermia, or a hike helicopter. So it's basically like environmental concerns or how am I going to get this patient out of here? So you don't see any obvious blood. You do like your sweep under the patient. There's no blood. Airway, I think we're going to get to that in just a minute. So he's not bleeding. Airway's open. There's no ice. They call it like an ice mask. There's nothing obstructing the airway. He's breathing at 8 a minute. Is that fast, slow, normal?
Better than none, but a bit slow.
Yes. So he does have a weak, kind of a thready pulse. He's bradycardic, but he does have a pulse. He's cool to the touch. So do you see any reasons that you would do CPR? He's got a pulse. Good. We talked about what you would do differently, but in this patient, when you're assessing for a pulse, what would you do differently in a hypothermic patient?
Wait for up to a minute for a pulse.
What about for breathing? Everything's extended, right? He's going to be bradypneic. He's going to be probably shallow respirations. It's going to just take longer. Pay more close attention. And the distal pulses are going to go away first, of course. So you don't undress the patient, but you'll want to check like a carotid or a femoral pulse. More likely going to be a carotid here. All right, bear with me. I might be reading a lot here, but basically this is everything we talked about in the guidelines. I don't want to belay this point and just drag this out because that's what the journal club was for. So what are the contraindications to CPR in this setting? Why would you not do it? Sorry, not this patient in general. Why would you not initiate CPR in a hypothermic patient in the field?
Obvious death.
Right. They have an ice mask over their face. They clearly have an asphyxiation cause of death. They have a decapitation. Like transection of the thorax, like something obviously traumatic death, and which is kind of the same in avalanche rescue, honestly. And what are the changes to CPR you might do in an extended extrication hypothermic patient?
Less frequent drugs, and it's going to be a long haul.
Doing something. Sorry, Drew, go ahead.
Less frequent drugs, and it's going to be a very long CPR.
Right. So in the field, let's say you're in a typical SAR team size. It's not huge. You don't have like this team of 20 people with you. You're going to have like a 4, 5, 6, maybe even less number team. So you're going to be doing CPR for a long time if it's just you guys. You're not going to be carrying a Lucas into the field, which, if you don't know what a Lucas is, it's like a robotic, manual or mechanical CPR device. They're great for EMS, but battery doesn't last forever, and it's probably not great in the cold. So there's something called intermittent, kind of interrupted CPR, and those were in the guidelines, and they're basically you do CPR for a little while, and then you go for a little bit further of your extrication, and you renew CPR, pause, get out of there. So it's how you can somewhat do CPR while extricating. And if they're truly hypothermic, it's essentially like they're cooling. So they have a significantly increased chance of survival compared to a typical out of hospital cardiac arrest. So it should be beneficial. The rest of this is in the guidelines, so I won't belay that. So you check vitals thoroughly. Heart rate's 41, respiratory rate 10. You do a core temp check. It's 25 degrees Celsius. So what degree of hypothermia is that?
Severe.
Yeah, severe, bordering on profound if he's like this altered. So what do you want to do?
Start warming him up, bundle him up.
Yep, he looked kind of appropriately clothed, but it's obviously 25. It's like really cold out. So let's see what we've got to work with. Let's say we exploded this patient's gear. We've got all this, which is pretty impressive. So we got a bag. We've got, looks like a sleeping bag. We've got a tarp. We've got some water. We've got a first aid kit. We've got sunglasses for him. We got extra light for us if we need to take a long way out. So with all this gear, do you think you'd be able to make a burrito wrap? Yeah, so I would do that. Let's say his clothing is dry, so we don't even have to worry about that. So we just kind of make our burrito wrap and kind of go from there. Does anybody know an indication for removing a patient's clothes in the field? Why would you ever do that? Anybody know?
If their clothes are wet.
If they're wet and you don't have a vapor barrier, it's a thing you could possibly do. But if you have a vapor barrier and you have good heat packs and you have a good burrito wrap, I'd probably just leave the patient's clothes on, because they're gonna, if you have a good vapor barrier, that patient's warmth is gonna stay inside the burrito, and you're gonna take the risk of exposing the patient. So I'd have to have a pretty solid reason for taking their clothes off. All right, so you got them in a nice burrito wrap. Here's how to make it, basically. You wanna have the vapor barrier like the first layer and have any gel packs or chemical packs you have inside of that. And then you put them in at least one sleeping bag, more the merrier. And then you might, if you have a pad, put that underneath. It'll give more cushion against the cold ground. And you can use that as padding when you're extricating the patient. And then you want like a durable tarp outside. And there's an example right there. We mentioned the chemical packs earlier. I would not apply the chemical packs directly to the skin. I would have some thin clothing layer in between a chemical pack and a patient, or a gel pack and a patient. And it was mentioned in the guideline discussion, but if you're going to put a warming device underneath of them, make sure you have a way to assess their back for burns. they're more susceptible to burns if they are hypothermic or have frostbite, and they're numb, they're unresponsive. They can't tell you. All right, cool. You guys recognize this picture? It's like we just talked about this. So you should be able to use the gear of the patient and yourself based on this article to successfully treat this patient, right? All right, so when you're transporting this patient out, what are some things you really want to remember? You're loading him up, you're moving him, you're getting into the ambulance. What do you want to keep in mind? Is it a good idea to like immediately stand the patient up straight? Why not?
You want to avoid the after drop from getting any peripheral cold blood back to the core.
He's also unresponsive, but in general, you don't want to stand them up. And what's another thing that you can cause by like roughly jostling a patient like this? Severe to profound hypothermia. What are you at risk of causing?
Cardiac dysrhythmias.
Mm-hmm. Particularly VFib, which is not great out in the field. To segue just a bit, there was an article that we talked about last year, and I'll probably include it again, just like a brief case report. It's a patient in a ski resort. He was like in not technically backcountry, but he's just outside of bounds. They got to him quickly. They unburied him really quickly. And he was kind of groggy when they got him out. He was in very thin layers, but they got him out. He was not asphyxiated. He had a good pocket, and he immediately stood up and immediately went into cardiac arrest. So they had like this amazing save, great scene time, fantastic like shoveling ability, and they got him out real quick, and then he stood right up because he didn't listen to them and died. So it is actually pretty important to keep them as flat and as gentle as you can. So you get on scene and you got all your rescue gear now. So you package him up, he's in a burrito wrap, you got him in a litter, and you're getting him out. So you meet the EMS crew at the trailhead. You recheck vitals, which you should be doing. You don't just check on scene and then kind of assume they're not changing. Heart rate's about the same. He's actually got a decent blood pressure, 97/62. I'm sure some of you are seeing that and terrified, but well, that's a decent map actually. Respiratory rate slightly better, and you improved his temperature by a whole degree Celsius, which is pretty good for your extrication, which is actually pretty good. All right, so can somebody summarize everything we've done for the patient and give a quick sign off report to the EMS crew? What the call was, what the story was, what you found, what you did.
Was he 45 or 54?
45.
Yeah. 45-year-old male who was last seen last night by his wife when he went out for a hike. There was a snowstorm on the portion of the trail he hiked last night. Found him. She called this morning. He was found unconscious, unresponsive with, what was it, bradycardic, hypothermic. No obvious trauma. Warming measures are taken. Here's your patient.
I would, so the paramedics are going to be the team that later presents to the ER team, right? So what are things you want to specifically make sure eventually that the hospital knows of? You want to make sure you know, like, yep, you can check a blood sugar. You want to know patient's age, last seen, be very descriptive in like what you found on scene, patient's vitals, any change in vitals. If there's any signs of trauma, because I can definitely tell you that the cardiothoracic surgeon is very much going to be interested in trauma or any concern for asphyxia. So definitely make sure that you make sure that point gets across. Okay, so we're going to, I believe this is the end of this portion, right? All right, so now you're no longer a search and rescue team. You're all now a EMS pre-hospital team. Let's say you're ALS crew, which is advanced life support. So you have more kind of freedom in your treatment that you can do, higher level of training and resources available. So the vitals that you get are exactly the same as they would just were. And we've just gone over this. So at this point, based on what we've got, what type of hospital would you prefer to get this patient to?
So I think I would prefer to get this patient to like a larger facility, potentially with like rewarming possibilities and like ECMO. The caveat there being that if it's within an hour of transport time, if it's going to be an extended transport, the nearest facility that's going to be able to provide like more definitive care is going to be our best option.
That's going to definitely be a call to the medical director of the EMS crew, I believe. I'd be surprised if that doesn't get notified to the county medical EMS director. Not sure if CJ's still on the line, but he was working at a hospital that I work at as well. There's actual rooms in the ER, something like 10 to 11 rooms, hospital beds, like 16 that you can actually staff. There's at night one doctor, and it's you in the ER, and upstairs is like a ACP hospitalist. So rather small critical access hospital, despite having Roanoke Memorial Hospital, which is like 800 beds, tertiary care center, 45 minutes down the road. So it's rather likely that your director or your algorithms or your recommendations you get in cases like these are to go the nearest hospital. But you would definitely request to go to a tertiary care in this setting.
Yeah, a lot of the time, unfortunately, CPR will go to the nearest hospital. And even if, you know, it was like trauma and they were going to go for a trauma center and the patient drops, they will sometimes even go to a tiny critical access hospital for a traumatic arrest, which you're like, oh my gosh, it seems like hypothermia, especially because we know that they tend to last a little longer, would be one of those reasons I'd be like, call the helicopter. And I know the helicopter doesn't like to fly doing CPR, but like, this is one of the times you should. Yeah. So those are one of the times where, again, we're like you said, if it's less, that hospital is 54 minutes to Roanoke Memorial, our tertiary care center. So that might have been one of the times I would have said, go down the street. Our local crew was not excited about doing that.
Mm-hmm. Yeah, it's kind of hard to get most people to wrap their heads around how different this resuscitation is going to be. So in an ambulance, other than warming the bay of the ambulance to 24 Celsius like they recommended, what else do you think you can actually do to warm a patient during transport?
So hopefully we have the ability to like warm fluids and provide warmed fluids. I know
use this case for our fellowship day. What was it, 2 months ago, 2.5 months ago? And we did like, it's awesome, like on scene. They the fellows rode along in an ambulance, and then we went to a sim center. Turns out you really can't warm fluids in an ambulance.
Yeah, I'll kind of, because a lot of people want to do warm fluids. That's always the first answer. And even in an ambulance, like if you imagine you pull it out of a warmer and it's now running through, like say you could get it almost as hot as you wanted, right? Like the trauma rooms that are baking at like 80 degrees. By the time that fluid runs through the tubing, which is exposed to room temperature air, that fluid's probably going to be 80 degrees. Sorry, and I'm back in Fahrenheit. So if you're moving your patient closer to 80 degrees, you might not be getting them much warmer. And 80 degrees is like still in the like really cold range, right? So the warm fluids actually tend to not do a whole lot unless you have one of like the hospital grade, super fancy, really, really, really warm hotline kind of type warming devices. So there's some ways to microwave it too, but you probably don't have a microwave in the back of an ambulance. So I gave our fellows a whole bunch of grief over that one.
I think they also gave 3 liters of fluids during transport. So they're not going to be that fluid down, right? Like that guy was out there as an afternoon, evening hike, and you got to him in the morning. I don't know about you guys. I don't usually wake up at night to drink. So he's probably not that markedly dehydrated compared to baseline. He supposedly had a lot of water during the hike. So during the hike, he was probably euvolemic, or at least close to. So he's just laying out there overnight. He probably wasn't sweating. So I don't think he's going to be too dry.
Yeah, and you get a little bit of cold diuresis, but that's still like your bladder is going to be like, super full at a liter. So,
All right. So what else can you do? Basically warm up the back of the ambulance bay, put a bunch of blankets on, and in supportive care indicated by the patient's vitals and neurologic status, right? If you have heat packs, again, don't put them directly on skin. Sorry, there's a lot of clicks I have to make here. So now that you're in there's no wind, there's no elements anymore, you're in the back of an ambulance. Now I'd say is the time that you can get them out of the wet clothes and dry them off. That's going to do a huge amount, and then put them back inside the warm blankets.
and Justin's point here is really important, right? Like, warm the patient has a question mark. Like, can we really even warm them? You can do a lot to prevent further heat loss and further cooling. But like if they're, and now again, if they're mild or like cold stressed, you can probably warm them up. But if they're severe, profound, like you're doing CPR, all you're doing is preventing further loss.
So I think it's in the WMS guidelines as saying active rewarming. I'd probably go a little bit further and say it's not active rewarming. But
You can make attempts. It's not going to be fruitful until you start to do the maximally invasive stuff.
Right.
That's my opinion. But
basically, don't let them get colder. So if you're going to go ahead and intubate this patient, what are you going to kind of plan for?
This is
Might be-
a terrific candidate for innovation.
Do you think he's eventually going to need it? So we'd say you're doing rapid sequence intubation, which is basically you're giving a sedative and a paralytic to allow you to do an intubation. Would you do changes to your doses?
I'd do lower doses.
Yeah. And ideal location, by that meaning back of an ambulance that's bouncing around the highway. It's not the best spot. Is if you've got like, granted, it's going to be tough to get a pulse ox, which is the little thing that goes on the finger and checks your oxygen level. It's going to be tough. He's going to be cold. He's probably not going to have the best peripheral pulses in the finger, so you're not going to get a great reading there. If you have end-tidal CO2, that'd be what I'd want to use.
granted, your end-tidal CO2 will be low because if if they're not making metabolic stuff, they're going to be living low. So it's a little bit falsely depressed and maybe unreliably low.
Yeah. So there's not really a great way of assessing this, right? But it's probably going to be a little bit easier in the ER with all the resources you've got, anesthesia if you need it, depending on the hospital size. So if you can protect the airway somewhat, it's probably a good idea to kind of less is more in this setting, which is in general for the EMS transport for patients like this. We already talked about that point. All right, how do you want to take it? You're in the ambulance now, so how do you want to check the temperature?
I can tell you the thermometers we had in the ambulance were the temporal artery ones. So yeah, I got nothing.
Mm-hmm. Sorry, I'm scarfing food so I can actually get something in my stomach. Let's say he's not intubated. I'm assuming you're not going to do an esophageal probe then, right? You only do that on intubated patients. You could potentially do a rectal temperature at this point. You're in a protected environment, but it's probably not going to be that great of assessment of a core temp. You might still be undressing this patient and not doing what you're trying to do. What else would you want to do?
How did we get a temperature in the field? Just do the same thing. So at least you have a baseline to go off of.
I always like comparing like to like.
I will warn you, pretty much all of the field thermometers, if they are, I believe it's under 92 or 90, we'll just say ERR. So that's a good sign that if it comes out 98.9, you're like, maybe this is not a hypothermic arrest, but, or severe hypothermia, maybe there's something else going on. But if it says error, then you're like, oh gosh, okay, maybe this guy is cold. And that's pretty much all it is. It becomes a binary test. Is he cold or is he not cold?
A lot of time that's what I get in like my DKA patients coming by ambulance. It just says high or over 500 or something. So something like that.
It might have been LO. I can't remember. There's two different brands, but even like the hospital ones, it gives you like either ERR or LO, kind of like the glucometers.
Getting there. There we go. All right. So you're hoping that you have an ALS ambulance in this case. And let's say we do. But state to state, county to county, they might be different kind of designations of what a BLS versus an ALS ambulance stocks and what the training requirements and algorithm allowed treatments are. So it's kind of variable, actually. So you're still technically in like an austere setting. You're pretty resource limited, even in a like advanced ALS ambulance. Okay, so that's pretty much it. Can somebody take the initiative and kind of summarize what the EMS portion did, and then take that in addition to what everything has happened, you're now presenting to the nurse, the doc, and the whole team in the hospital.
Yeah, so hey everybody, this is our patient. He's a 45-year-old male who was last seen yesterday as he went on a hike, is down for an unknown amount of time, was found by local wilderness rescue, unconscious and hypothermic. They initiated like passive rewarming and extricated. Since we have him on scene, we've continued like passive rewarming with blankets and gel packs, and have monitored him en route. Last set of vitals is pulse 45, BP 97 over 62, respirators of 12. The last temperature we had was of 26 via our like temporal or epitympanic probe.
Thanks for keeping such a good track of the vitals. What was his temp on scene, and what did you get him up to?
Temp on scene was 25. Most recent temp was 26. So overall, we've had 1 Celsius increase.
All right. Let me switch gears here for a minute. All right, so everything he just said there, and they somehow got a 93%. Oh, GCS on arrival 7. So let's say you have like 20 minutes of notification. You get like your medcom, they give you a phone call and they give you this report and they say, hey, you've got a hypothermic, severely hypothermic patient coming in. What do you want to get ready? What do you want to think about in these like 20 minutes that you have to prepare? Because it's going to be different than like a regular ACLS, right? All right, Chris, and let's say you're the resident you're the senior resident in the ER. Your attending is from like Mexico and has never seen somebody colder than 99 degrees Fahrenheit. So you're running this, it's just you. What do you want to think about? What do you want to prepare for?
I guess starting with so airway, so probably making sure that I have things to bag and or intubate, since things can of course change in the ambulance if he does become unresponsive or needs, intubation. In GCS less than 8, you think about intubation, but if he's protecting his airway well, maybe he can hold off to see if we're able to kind of, improve things without that. Kind of same with breathing for cardiac, just lots of gentle kind of movement and kind of preparing the whole team and just kind of being very gentle, kind of keeping him supine and stuff. Getting kind of some IV access and thinking about what type of access we'll have, if we'll need kind of more advanced central line, if he's going to be needing like pressors or anything else. And then for, disability, I guess kind of cardiac, is there other trauma, which it doesn't sound like it, but still kind of just thinking about that in the back of your mind. And then for kind of rewarming, kind of thinking about, using like bear hugger, kind of the warmed fluids kind of later on, and just kind of going from there.
Definitely, I agree with that. I would say to kind of further that a little bit, you got some time. So if there's a specific room in your ER that's the most able to have lots of space, so you want a big room, there's going to be a lot of stuff going on. So ask for a big room. A room that you can increase the temperature on. A lot of the rooms I've worked in, there's no specific thermostat for that room, but some way to increase the temp, right? Any ambient temperature increase you can do is going to go a long way. Just kind of brief your team like, hey, this is going to be a lot different than a regular resuscitation. You guys are probably going to be seeing some stuff that you've never seen before. It might make you a little shocked, and this is going to take a long time. So they're going to be working at this for a long time. Also, I would have a respiratory there, of course. We'll go through a little bit more of the invasive rewarming things that I don't think we've gotten to, so I don't want to belay that point right now, but you might want to get some specific temperature probes, right? Anything you have. So have you heard of a temperature sensing Foley? It's essentially just a Foley with a thermometer on it. It's nothing crazy. One hospital I work in keeps like 30 in one room, so we're stocked.
So they do. We had plenty when we had that case that we cannulated all 30 of them, which is why when we couldn't find an esophageal probe, I shoved the temperature fully down the esophagus.
Yep. So you can use it. So that, like you were mentioning, if he's not protecting his airway, GCS is 7, less than 8 intubate, right? So he's probably going to get tubed, so you can do an esophageal thermometer probe. So I don't know, have all your meds ready, have your RT prepped, ask your RT to bring a rewarming circuit for the ventilator. So you can rewarm with humidified air that's rewarmed through the ventilator even. Anything helps. We'll get into more of the invasive stuff, but I'd want that prep too. Now, unless you've got like every med student in your whole nearby university ready to go, you're probably going to want a Lucas device for this. So I'd ask for a Lucas and a bunch of batteries because it's going to take a while. Granted, he has a pulse right now, but this is all stuff you want to think about.
Which is actually really useful too when you're at a really tiny hospital and you either have one Lucas battery. Your EMS agencies are often very useful and can help, like they can bring them and we'll come drop them off or bring personnel to help do CPR. I did page once for all medical students in the hospital to a room, and that can bring variable results. So use cautiously.
Yeah. I remember back in
Your Lucases not have a power plug?
No.
Huh.
My counties did. They were great. You could just plug them into the patient's wall.
Yeah, one of the hospital where we paged for all medical students, we didn't have a Lucas. So that sometimes you could get EMS to bring you a Lucas because we didn't even have one in the hospital, but Lucas was a fairly new device. We had the other geezer squeezers too, but the auto pulse.
Just to remember, like it's going to be different than normal. Kristen already ran us through all that.
And that's just important too, is like setting that scenario. Cause when we heard the radio call on ours too, like trying to let the nurses know, like, this is going to be weird. We're not going to like do 20 minutes and then like call it a day and walk away. We're going to be doing like, they're like chest tubes. Why are you doing chest tubes? But setting that stage is actually really important if you know that it's coming.
My dog wants to play and she's getting old. So anytime she gets to play, I try and make sure she gets a little chance. So what do you think? You're going to shock this patient every like 3 minutes? Every pulse check, every 2 minutes, sorry. No? Yeah, good. So we can talk more about ECMO, but does anybody know like the two kind of umbrella categories?
Like VV versus VA.
Right. So what do you get kind of like, what are you supporting differently between the two types? Like
My
VV,
understanding is VV
what do
is
you
just
provide?
cardiac support.
sorry, was that VV or VA that you said?
VV, I think.
You said, sorry, VV does have cardiac support or does not have cardiac support?
I'm not sure. I guess fixing to learn.
Well,
Right.
if you think about it too, it's one of them will really kind of just pull blood out right before it goes to the lungs and then put it right back in right before it goes to the lungs. So it won't really like bypass much of the pump system. So if your pump's not really working well, it's not going to do a whole lot. Versus one that goes from the V and into the A will bypass the lungs and it'll bypass the heart. So they sometimes call it heart-lung bypass. I mean, if you think it bypasses both of them, well, then it's effectively doing the job of both of them. And that's where it's like one of the biggest differences.
Mhm. So if anybody has seen that, that's a chest tube. So why do you think, anybody know why he got a chest tube? Why would you think about doing a chest tube on a hypothermic patient like this?
Could you put warm fluids through it?
Yeah. Do you know where you'd want to put a chest tube in a rewarming scenario like this? And how many chest tubes?
I would say I'd first go on the side with not the heart because the heart is irritable and you don't want to be poking it.
It's definitely a good thought. I like that. You're always going to be somewhat limited by the space in the room, but I would think about the right side. Now, you'll probably need two chest tubes on the same side. Do you know why?
Fluid in, fluid out.
Yes. So there's kind of two main types of chest tubes, I suppose. There's like either way they're going in and causing a potential pneumothorax. So let's say you want to do a type of chest tube that allows you to put fluid in. You don't need some massive system for this, right? But would you place a open thoracostomy, which is like this large tube like this, like a finger thoracostomy, if you can call it that? Or do you know what a pigtail thoracostomy tube is? Or a percutaneous? So that's like a Seldinger technique. You're going kind of like a central line technique, just going straight into the chest wall. But this patient doesn't have a pneumothorax, right? He doesn't have an injury. So when you enter the chest wall, there's no potential, this is just a potential space, right? The potential space has not accumulated with fluid or air. So you would want to start with a typical incision type finger tube thoracostomy. And then you're going to cause a pneumothorax, giving you space to do a typical Seldinger style pigtail type tube. Now you can put both tubes. I'm just taking words out of CJ's mouth. You can take both tubes and put them into the same large hole, or you can do two separate openings.
That title for publication got rejected. 2 tubes, 1 hole.
So think of the lung in a 3D structure, okay? Patient's going to be, when you're doing a tube, either supine or slightly elevated, but laying on their back. So you probably want to put one tube antero-posterior and probably one tube a little bit opposite of that. That way, when you're putting fluid in, it's going to cross the entire surface area of the lung. So we've debated this amongst our fellowship and not really come to a consensus, but there's 2 ways to do this. I don't think there's a great study that really shows one helps, but theoretically you could say one or the other. But you could do dwells, which means you're putting fluid in and then kind of clamping, letting the fluid sit there for a while, rewarm the surface of the lung, and then drain it out. And at what point would you do that? Well, you can use kind of the temperature sensing Foley to check for temperature changes and then kind of change at that point. Or you could instead do a continuous input with a continuous output. We've actually debated that quite a bit. So
Future research to
yep.
answer that question.
So from a practicality standpoint, getting fluids through a chest tube, I mean, like connecting a fluid bag to a chest tube is not really straightforward. Would you be sending fluid in through like a pigtail because you can actually connect it to something and then out through a chest tube like a normal one?
Mm-hmm.
Okay.
That's exactly it. So in our,
Do you want me to steal the pictures real quick?
yeah, if you have access to that, it'd be perfect. So I wasn't involved because it was before my time, but our fellowship designed kind of like a, what do we call it? The cold cart?
So yeah, hypothermia cart.
Hypothermia cart. So it had, this awesome nurse took pictures of every single little device and how to hook it up. So you just kind of go through these pictures and you can find how to set up this device and just kind of go through it.
I'm not host. Can you?
Oh, yep. That's what you.
So, and you actually don't need you only need the connectors if you try to do the try to infuse into the large bore chest tube. The pigtail has a lure lock on it. So let me see. Let's make sure.
You should be co-hosting.
Can you guys see those pictures up? Hopefully, yeah. So the pigtail has a lure lock on it. I put a little 3-way stopcock in there in case I needed to vent it. As you can see by all of the blood, that's what happens when you try to put the pigtail in first. And there's no potential space as you poke the lung in a patient that doesn't have the temperature for the coagulation factors to work. So that turns into a crazy big mess. This is why I recommend doing the large bore first, but you can essentially infuse, and you see this little blue connector that's a lure lock that hooks straight up to the hotline, which is one of the like brand name warmers. So you can run your fluids in at 104 Fahrenheit or 40 or 41 Celsius, and then just drain it via the large bore chest tube in a very typical fashion, except you'll overwhelm your chest seal. So you have to get a big old canister in front of the vac, but yeah.
Yeah, so you basically want your typical like pleurovac setup as the last point in the chain, and you can somewhat daisy chain it along. I've done that with the paracentesis before. You take like one typical large volume vacutainer device, you have that the output chest tube into that, and then you can hook that onto another one and another one, and eventually into the pleurovac like tower-like device. That gives you your water seal, so you're not going to cause a problem, and allows you to not overload your system. It is a little bit of a kind of high level discussion here, but it kind of shows you what medicine can kind of get into, the complicated, weird stuff too. So help, who do you think you might need in this case? What consults might you be making?
Put a call out to CT surgery if you're thinking about going ECMO.
Yeah. So ECMO, and then what's like almost the exact same rewarming rate per hour as ECMO, but ECMO is going to be preferred. They do it all the time in open heart surgeries.
It's kind of a nuance. ECMO is a little tiny box, but in the operating room, they use a big old huge cart.
Mm-hmm. Like you could do cardiac bypass isn't even an option. Dialysis with a rewarming circuit is an option, but ECMO VA is going to be like your quickest. And that's not to say you're not doing the other stuff too. You're going to be doing the chest tubes. You're going to be doing, you could be doing like bladder dwells where you're putting fluid into the bladder with your temp sensing Foley. When you start seeing a decrease in the temp, you drain it out and put the fluid back in. And at that point, you can, if you're doing dwells in the chest tubes, you can switch that out at the same time. So it's a good way to know if you're doing the dwell route. So it's just, this is all kind of at the same time, a lot of stuff at the same time. So you got this on the monitor. What's that rhythm?
We can't see your screen.
Ah, shoot, no wonder. It felt different. Because I took it back over from CJ, that's what it is.
Sorry.
No, I didn't even pay attention. All right, you see this? Anybody see a rhythm strip here? What is that? Normal, abnormal?
Abnormal for subs.
Shockable, non-shockable?
Lots of shockable.
Shockable.
Right, but in this case, from a severe hypothermia, it is a shockable rhythm, but based on like the WMS versus the AHA versus whatever guidelines you want to follow, you're not just going to be shocking every pulse check, right? So you start CPR, you do one shock, you don't get a change, you intubate, you're doing the humidified heated air, you got a esophageal thermometer, you do a FEMS central line. Now, keeping in mind with VA ECMO possibilities, is there anything you'd want to keep in mind when doing a femoral central line? Who's done a femoral central line?
Could you use like a cordis or something so that you could save the introducer? I don't know if it has any kind of overlap with the catheters for like the ECMO, so that you might potentially not need to do multiple sticks.
The introducer in and of itself is not going to save you that, but I think what Justin's asking is right along the same lines. You need to use a wire, much like a central line. It's a much bigger wire. It's longer, and it's you can't exchange it in your normal central.
Okay.
But if you're gonna do that, there's very specific placement that you have to be aware of when you put your central line in.
Right. So let's say you're in a crash FEM central line in a code, you basically feel for a pulse and you just go next to it immediately and get what you get. But in this, it's not like a absolute emergent line. You can do an IO if you need to. You can drill in the tip if you need to. So this, keeping in mind for potential VA ECMO, you want to make sure you don't penetrate and enter the superficial FEM, because that's not going to be a proper vessel for them to cannulate, and then you just blow that whole site. So make sure you're in like the common FEM. And not
like actually, when we do them in the ER too, like half the time we put it in common FEM, and then you go up higher and you're like, crap, right? Like, so if you're doing 2-point compression studies, most of your ultrasound faculty are pretty stingy at making sure you actually hit the confluence, which is really high. So the same thing goes when you place that wire. If you're learning how to like do cannulations, you really got to make sure you're in the common FEM, especially for distal perfusion, both for artery and for vein, but especially for artery. So especially if you're doing the art line.
So the reasons for going femoral, obviously, if you're going to do ECMO, I don't like to do IJs if I'm in any type of emergent crash situation, because you can't do it blind. Well, 2022, you shouldn't be doing a blind IJ. You can do a subclave, but you're going to be right next to where the chest tubes are going to be, and you're going to be right next to where the Lucas and CPR are going to be. So femoral's out of the way. So that's why I like femorals in a case like this. And if most people are right-hand dominant, most people are going to go for the right femoral site. So I don't really care where I put mine. I'll lean over the patient if I need to, or just kind of lean to my left and do it in the left fem. So if you're worried about blowing a site, you could use a left fem. So let's say you got a Chem 8, which, if nobody knows, it's kind of like a rapid version of a basic metabolic panel. You're given warm fluids between 40 and 42 Celsius, and now you got to make some phone calls. We've already talked about all of this. You got a good team. Crack team is on the case. So we're doing the typical things, external rewarming, like the bear hugger versus Arctic sun, and it's like warm air versus like warm fluids going through a device, and some external heat packs, plus the fluids through like a Foley that's minimally invasive. And then you get the really invasive stuff like the chest tubes and the ECMO. Peritoneal lavage. I've never done a DPL, which is diagnostic peritoneal lavage, so I don't think I'd jump straight to this because I've never done just the diagnostic version. So these are just the rewarming rates. So VA ECMO, I'm not sure if you see my pointer here, but it's like 6 Celsius per hour increase. So pretty darn fast. 9's the highest, which is like cardiac, it's just bypass. Yeah. But may as well do VA here. And then your chest tubes, you get 3 Celsius per hour. And then your typical warming the surroundings, like 2 an hour. So you can kind of add this up and you're get some rewarming rates that can be quick. So you're getting some laps back. You've done CPR for 20 minutes. Can somebody pull up the Hope score online and calculate some of these numbers for me? And let me know if you have access to it so I know where it's happening. Looks like you're working. You have it? All right, anyway, we got 45-year-old male. Potassium is 4.8. CPR duration is 20 minutes. His temp is 27 Celsius. So there's the score if anybody needs it, hypothermiascore.org. So here's his numbers. 45 is his age. He's a male. He was not asphyxia. 20-minute CPR, potassium 4.8, 27 Celsius. And then my participation box is blocking the bottom of that. So you crunch some numbers and you find that the patient, based on the Hope score, has a 54% chance of survival. What do you think about the odds? It's pretty darn
Compared to everybody else getting CPR, that's pretty great.
right. Compare a hypothermic arrest like this guy compared to a typical 45-year-old found down. It's incredibly different. And then we already talked about all of this. I recognize that picture from like a half hour ago. So these are kind of, yep, that was shown in Kristen's article as well. So here's his hospital course. So with ECMO and the invasive and minimally invasive rewarming that we performed, he then got to ICU and discharged with neurologic recovery. Good job, everybody. We saved him. Any questions? I know that was kind of high level stuff for a lot of the first and second year students here, even any residents here. This is stuff that I didn't learn during residency.
Things you learn the principles of, but actually learning the nuts and bolts and the how. I learned in my first few, probably as a third year, and definitely again as a fifth year resident. But, yeah. And then as a fellow, actually trying to make it happen.
To show the complete opposite end of the spectrum, and we'll do heat illnesses in a couple of months, but I was a third year resident, I believe, and I had a heat stroke patient, and my EM trained attending in a heat stroke was like, get me 650 rectal Tylenol stat. So IM trained, like dual boarded attendings can even not know this stuff if they've never really been interested in or been exposed to environmental medicine. So you guys definitely have a leg up. Any questions? This is, like I said, this is kind of advanced stuff. All right. I have a feeling we definitely stayed longer than usual. Yeah, well, thanks for bearing with me. But I figured this would be a little bit more fun than a typical just talk about article day. So hope you gained something from it. Any questions? All right, I'm going to end recording. My wife's teasing me. Sorry, it's like I said, technically challenged here. None of these buttons are working.